Hypertension in neonates is defined relative to gestational age and body size. A value above the 95th percentile for systolic or diastolic pressure is considered abnormal. When pressures exceed the 99th percentile, the diagnosis is severe hypertension, a level associated with higher risk of end organ injury. For term newborns, an approximate threshold is a systolic pressure greater than 90 millimeters of mercury or a diastolic greater than 60. This estimate helps guide quick recognition in clinical settings where percentile tables are not readily available. Preterm infants require more caution. Their normal ranges vary widely by gestational age, and what is hypertensive for a 28-week infant may be entirely appropriate for a 36-week infant. Reference charts tailored to gestational age provide the most accurate framework for interpretation. Defining hypertension precisely is important because overdiagnosis can lead to unnecessary intervention, while underdiagnosis risks silent injury to organs such as the brain, kidneys, and eyes. Consistent use of percentile-based definitions ensures that elevated pressures are recognized in time to guide evaluation and treatment. Hypertension is less common than hypotension in the neonatal intensive care unit, but it is clinically significant when it occurs. Reported incidence ranges from 2 to 30 per thousand admissions, reflecting variation in case mix and diagnostic thresholds. Several risk factors increase the likelihood of developing elevated pressures. Indwelling arterial catheters can injure renal or iliac arteries, leading to thrombosis or stenosis that disrupts renal perfusion and activates the renin-angiotensin system. Chronic lung disease contributes through hypoxemia and pulmonary hypertension, which increase sympathetic tone and systemic vascular resistance. Renal disease is one of the strongest drivers. Congenital anomalies, renal vein thrombosis, or acute kidney injury alter sodium and water handling, raising intravascular volume and pressure. Coarctation of the aorta produces upper extremity hypertension through fixed obstruction, often with lower body hypoperfusion. Medications such as corticosteroids, caffeine, and some inotropes also raise systemic pressure by enhancing vascular tone or fluid retention. Recognition of these risk factors allows early surveillance of vulnerable infants and timely evaluation when blood pressure rises unexpectedly. Renovascular disease represents the most common cause of hypertension in neonates. The kidneys play a central role in blood pressure regulation, and disruption of renal blood flow quickly activates the renin-angiotensin system. Renal artery thrombosis is a classic example, frequently related to umbilical artery catheterization. Thrombus formation obstructs blood flow, creating ischemia that drives renin release and persistent vasoconstriction. Removal of the catheter alone rarely resolves the problem once a clot has formed. Renal vein thrombosis is another important entity, often associated with dehydration, polycythemia, or sepsis. Venous congestion impairs renal outflow, leading to swelling and reduced perfusion of the parenchyma. The kidney interprets this as low flow and responds by raising systemic pressure. Renal artery stenosis, whether congenital or acquired, produces a similar effect. Narrowing of the vessel limits perfusion, which again stimulates renin release and systemic hypertension. Although less common than thrombosis, stenosis should be considered in persistent cases without an obvious cause. Congenital renal anomalies, such as hypoplastic kidneys, cystic dysplasia, or structural malformations, alter renal perfusion and function from the outset. These conditions create chronic activation of the renin-angiotensin system and sustained hypertension. Because renovascular pathology is both common and treatable, identifying it early is essential. Ultrasound with Doppler evaluation often provides the first diagnostic clue, allowing targeted intervention before long-term renal or cardiovascular injury occurs. Cardiac causes of neonatal hypertension are less common than renal or renovascular conditions, but they are critical to recognize. Coarctation of the aorta is the most frequent cardiac etiology. Narrowing of the aortic arch increases resistance to blood flow from the left ventricle, producing elevated pressures in the upper extremities while reducing perfusion to the lower body. Clinical recognition hinges on comparing upper and lower extremity blood pressures and palpating femoral pulses. Interrupted aortic arch is another obstructive lesion. Complete discontinuity of the arch forces systemic flow to depend on ductal patency. When the ductus closes, severe hypertension in the upper body may coexist with shock in the lower body. This lesion often presents early, and blood pressure screening in all 4 limbs can provide the first clue. Renal artery stenosis can also appear in syndromic contexts, particularly Williams syndrome, where elastin arteriopathy narrows both aortic and renal vessels. The cardiac association here lies in the vascular abnormalities that affect multiple arterial beds, including the great vessels. Routine measurement of blood pressure in all 4 extremities remains essential in any infant with unexplained hypertension. Identifying discrepancies between upper and lower limb pressures provides an early signal of obstructive cardiac disease. Prompt recognition allows timely echocardiographic confirmation and targeted intervention. Renal parenchymal disease is the second major category of neonatal hypertension after renovascular causes. Acute kidney injury, whether from hypoxic ischemic injury, sepsis, or nephrotoxic medications, impairs the kidney's ability to excrete sodium and water. The resulting volume expansion raises systemic pressure. Polycystic kidney disease and other cystic malformations increase intrarenal pressure and disrupt normal function, often producing sustained hypertension early in life. Congenital nephritis, though rare, can produce chronic inflammation and scarring that similarly activates the renin-angiotensin system. Endocrine disorders must also be considered. Congenital adrenal hyperplasia alters cortisol and aldosterone balance, creating excess mineralocorticoid activity and sodium retention. Primary hyperaldosteronism, though unusual in neonates, has the same effect, leading to persistent hypertension with hypokalemia. Medications frequently used in the neonatal intensive care unit can raise blood pressure as well. Dexamethasone increases systemic vascular resistance and enhances sodium retention. Phenylephrine, used as a decongestant or vasopressor, is a direct alpha-adrenergic agonist that produces vasoconstriction and elevated pressures. Even caffeine, in high doses, can raise blood pressure by increasing sympathetic tone and cardiac output. These causes are often overlooked because they fall outside the classic renovascular category, yet they are highly relevant in the intensive care environment. Careful medication review and targeted renal and endocrine evaluation are essential when hypertension persists without an obvious structural explanation. Hypertension in neonates often presents silently. Many infants are asymptomatic, with the first clue being an elevated pressure detected during routine monitoring. This makes consistent surveillance essential, especially in infants with known risk factors. When symptoms do occur, they are frequently nonspecific. Feeding intolerance, poor weight gain, or vomiting may reflect mesenteric hypoperfusion. Irritability or lethargy are common neurologic responses, but they can be subtle and overlap with other neonatal conditions. Tachypnea can develop either from pulmonary congestion due to elevated afterload or from metabolic acidosis secondary to impaired renal function. Severe hypertension may produce overt neurologic complications, such as seizures. Excessive pressure disrupts cerebral autoregulation, leading to hemorrhage or ischemia. Cardiac consequences are also possible. Sustained hypertension increases ventricular workload, which can precipitate signs of heart failure, including hepatomegaly, gallop rhythms, and respiratory distress. Because clinical findings are variable and often nonspecific, elevated pressures should always be correlated with accurate measurement and serial trends. Recognition of even mild symptoms in the setting of elevated blood pressure is vital to prevent progression to severe complications. The first step in evaluating neonatal hypertension is to confirm that the elevation is real. Multiple measurements should be taken, using the correct cuff size and ideally during a quiet state. A cuff that is too small will overestimate pressure, while one that is too large will underestimate it. Consistency across repeated measurements establishes reliability before labeling an infant hypertensive. Four-extremity blood pressures are an essential screen for structural cardiac disease. Higher pressures in the upper extremities with lower pressures in the legs raise immediate concern for coarctation of the aorta or interrupted aortic arch. This simple maneuver provides a powerful diagnostic clue. Physical examination can reveal important secondary causes. Abdominal masses may represent renal vein thrombosis, polycystic kidney disease, or adrenal pathology, all of which can drive hypertension. Careful cardiac examination for murmurs, gallop rhythms, or differential pulses adds further information about structural or functional disease. Ophthalmologic examination is also valuable. Retinal vessel changes, hemorrhages, or papilledema may be early markers of end organ impact from sustained hypertension. Although subtle, these findings underscore the importance of comprehensive evaluation beyond blood pressure measurement alone. This structured initial assessment confirms the diagnosis, narrows the differential, and identifies early complications that guide further investigation and management. Laboratory studies are central to evaluating neonatal hypertension because they identify secondary causes and uncover organ involvement. Urinalysis provides a quick screen for proteinuria or hematuria. These findings suggest parenchymal renal disease, such as glomerulonephritis or renal vein thrombosis, which can drive persistent hypertension. Renal function tests are the next step. Elevated creatinine or blood urea nitrogen indicates impaired filtration, either from congenital anomalies, obstructive uropathy, or acute kidney injury. These results establish both the cause and the impact of hypertension on renal function. Electrolyte evaluation is equally important. Hypokalemia in a hypertensive infant strongly suggests mineralocorticoid excess, whether from congenital adrenal hyperplasia, hyperaldosteronism, or exogenous steroid exposure. Identifying this pattern directs attention toward endocrine causes rather than renovascular disease. Direct measurement of renin and aldosterone levels can further define the mechanism. High renin with high aldosterone suggests renovascular pathology, while discordant patterns point to endocrine disorders. Imaging complements laboratory studies. Renal ultrasound with Doppler is the first-line modality, allowing visualization of renal size, structure, and perfusion while detecting vascular obstruction or thrombosis. Echocardiography is equally important to identify cardiac causes such as coarctation, or to assess whether systemic hypertension has already produced ventricular hypertrophy or dysfunction. Together, these investigations provide a comprehensive understanding of both etiology and consequence, guiding targeted treatment in infants with confirmed hypertension. Management of neonatal hypertension begins with identifying and correcting the underlying cause whenever possible. Treating renal thrombosis, adjusting medications, or repairing a cardiac lesion directly addresses the driver of elevated pressure and prevents reliance on long-term pharmacotherapy. Blood pressure reduction must be deliberate. Neonatal cerebral autoregulation is fragile, and a rapid fall in systemic pressure can reduce cerebral perfusion, precipitating intraventricular hemorrhage or ischemic stroke. For this reason, gradual reduction is the rule. The initial target is a 25% decrease from baseline pressure. Once this controlled reduction is achieved, pressures can then be normalized over hours to days. This staged approach preserves perfusion to vital organs while still reversing the risks of sustained hypertension. Monitoring for end organ involvement is essential throughout therapy. Renal function, cardiac performance, and neurologic status should be followed closely, since hypertension can silently damage these systems. Ophthalmologic examinations remain important to detect retinal changes that signal vascular injury. Avoiding precipitous blood pressure drops is the cornerstone of safe management. Careful titration of therapy, guided by both numbers and organ function, ensures effective and safe control of neonatal hypertension. Angiotensin-converting enzyme inhibitors are among the most commonly used medications for sustained hypertension in neonates. They target the renin-angiotensin-aldosterone system, a key pathway in many secondary causes of elevated blood pressure. By blocking the conversion of angiotensin 1 to angiotensin 2, these agents reduce vasoconstriction and limit aldosterone-mediated sodium and water retention. Enalapril is frequently chosen for longer-term management. Dosing typically begins at 0.05 to 0.1 milligrams per kilogram per dose by mouth every 12 to 24 hours. The extended dosing interval makes it practical for outpatient care in stable infants. Captopril is shorter acting, with dosing between 0.01 and 0.5 milligrams per kilogram per dose every 8 to 12 hours. Its rapid onset allows more precise titration in the acute setting, though the need for multiple daily doses can be less convenient. Monitoring is critical when these medications are used. Both agents can reduce glomerular filtration by lowering intraglomerular pressure, so creatinine and blood urea nitrogen should be followed closely. Hyperkalemia is another predictable effect due to reduced aldosterone activity, and regular electrolyte surveillance is necessary. Despite these risks, angiotensin-converting enzyme inhibitors are considered first-line therapy for many cases of neonatal hypertension, especially when renal or renovascular causes have been excluded. Their ability to provide effective, sustained blood pressure control with oral administration makes them well-suited for both inpatient stabilization and outpatient continuation. Several additional classes of medications are used in neonatal hypertension when angiotensin-converting enzyme inhibitors are not sufficient or not tolerated. Calcium channel blockers are effective oral options. Amlodipine, dosed at 0.05 to 0.3 milligrams per kilogram per day, is given once daily and provides smooth, sustained control. Nifedipine, at 0.25 to 3 milligrams per kilogram per day, in divided doses every 6 to 8 hours, has a shorter duration. Sublingual administration should be avoided, as it can cause unpredictable rapid blood pressure drops. These agents reduce systemic vascular resistance by relaxing vascular smooth muscle and are particularly useful for long-term management. Beta blockers provide another option, especially in infants with hyperdynamic circulation. Propranolol is dosed at 0.5 to 8 milligrams per kilogram per day, divided every 6 to 12 hours. It lowers pressure by reducing heart rate, decreasing renin release, and diminishing cardiac output. Contraindications include asthma, where bronchospasm may be exacerbated, and advanced heart block, where conduction delay could worsen. Diuretics are often used as adjuncts, particularly in infants with volume overload or chronic lung disease. Hydrochlorothiazide, dosed at 1 to 3 milligrams per kilogram per day every 12 to 24 hours, promotes sodium and water excretion, reducing intravascular volume and systemic pressure. Their role is supportive rather than primary, but they can be valuable in specific contexts, such as bronchopulmonary dysplasia with fluid retention. Choosing among these classes depends on the infant's underlying condition, tolerance, and concurrent comorbidities. Often, combination therapy is required to achieve stable blood pressure control while minimizing adverse effects. Severe hypertension in the newborn is a medical emergency. It is generally defined as a systolic pressure greater than 180 millimeters of mercury or the presence of symptoms such as seizures, heart failure, or encephalopathy. At these levels, the risk of acute end organ injury is high, and prompt intervention is required. Intravenous antihypertensives are the cornerstone of therapy. Labetalol provides both alpha and beta blockade, reducing vascular resistance without compromising cardiac output significantly. Esmolol, a short-acting beta blocker, allows rapid titration and is useful when heart rate control is desired. Nicardipine, a calcium channel blocker, is effective for vasodilation and provides predictable dose-response characteristics in continuous infusion. The guiding principle is to avoid rapid or excessive pressure reduction. Neonatal cerebral autoregulation is limited, and precipitous drops in blood pressure can lead to ischemic stroke or intraventricular hemorrhage. Instead, the goal is a controlled reduction of approximately 25% from baseline over several hours, followed by gradual normalization. This staged approach protects vulnerable organs while reversing the immediate danger of severe hypertension. Continuous monitoring in an intensive care setting is essential, as both undertreatment and overtreatment carry significant risk. Long-term care of neonatal hypertension requires a structured and multidisciplinary approach. Regular blood pressure monitoring is the foundation, since pressures can fluctuate as the infant grows and as underlying conditions evolve. Early recognition of recurrent elevation prevents silent progression to organ damage. Addressing the primary cause remains central. Infants with renovascular disease benefit from ongoing nephrology input, while those with coarctation or other structural lesions require cardiology oversight. Close specialty collaboration ensures that secondary hypertension is not simply masked by medications, but managed at its source. Medication regimens must be adjusted continuously. Doses that are effective in early infancy become inadequate as weight increases, and growth-related changes in renal clearance alter pharmacokinetics. Periodic reassessment of drug type, dose, and combination therapy keeps treatment both safe and effective. Family education is equally important. Parents and caregivers should understand how and why blood pressure is measured, what equipment is used at home when needed, and what signs of poor control may look like. Their involvement allows early detection of complications outside the hospital. Sustained follow-up that integrates routine monitoring, specialist consultation, and family participation provides the best chance for maintaining normal pressures and preventing the long-term cardiovascular and renal sequelae of neonatal hypertension. Chronic hypertension develops in a small subset of NICU graduates, often linked to renal parenchymal disease, bronchopulmonary dysplasia, or structural cardiovascular lesions such as coarctation. Unlike transitional fluctuations, this elevation persists and places infants at risk for silent end organ injury. Long-term surveillance is mandatory, with nephrology follow-up for renal disease and cardiology input for structural lesions. Antihypertensive medication doses must be adjusted frequently, since growth alters drug distribution and clearance. Ongoing assessment of renal function, cardiac performance, and retinal health ensures complications are not missed. Including the family in monitoring practices supports early recognition and timely intervention. Several points stand out when managing blood pressure disorders in neonates. For hypotension, clinical assessment of perfusion is just as important as the numbers displayed on the monitor. Cool extremities, delayed refill, low urine output, and metabolic acidosis carry as much weight as a threshold value. In cases where pressures remain low, despite high-dose vasopressors, adrenal insufficiency should be suspected and hydrocortisone considered. For preterm infants, the practical rule is that mean pressure during the first 2 days should approximate gestational age in weeks, which serves as a guide to identify infants at risk of inadequate perfusion. For hypertension, measuring pressures in all four extremities is essential to identify coarctation or other obstructive lesions. The most frequent underlying category is renovascular disease, often linked to catheter-associated thrombosis or congenital abnormalities, which makes renal imaging a priority. When antihypertensive therapy is needed, pressures must be lowered gradually. A controlled reduction avoids cerebral hypoperfusion and reduces the risk of stroke or intraventricular hemorrhage. Across both hypotension and hypertension, the unifying principle is accurate measurement and integration of numbers with clinical findings. Mastery of technique, combined with careful interpretation, allows early recognition and safe, targeted management of neonatal blood pressure disorders.